So good evening, everybody. I'm Tracy Milgram-Posner, the founder of BRCA Strong, where we inspire, educate, advocate, and empower providers, survivors, thrivers to eliminate the feeling of isolation and help you feel whole again. During COVID-19, we're doing educational Zoom calls and mailing out packages to women who are newly diagnosed or who are headed in for surgery or treatment. So if you or your family member need one of those packages, please feel free to reach out to myself or Kate, who's on the call, who's one of our board members. Tonight, we have a special guest, Dr. Sinno, gynecological oncologist, speaking tonight on ovarian cancer and some BRCA information. So what I will do is pass it over to him. Thank you so much for donating your time and coming on tonight. We're super thankful and appreciate all that you do in the community. Oh, hold on one second, we can't hear you.
There we go. It's because
there you go.
Yeah. So thank you all so much for having me. And it's a real pleasure to be here to speak with you all.
It sounds really low.
So I'm just going to hold this up. I apologize for that. But yeah, my name is Abdulrahman Sinno. I am a gynecologic oncologist. I practice at the University of Miami at the Sylvester Cancer Center, which is, I've been here for about 10 months. So I'm new to Miami and new to the Cancer Center. I did my training in gynecologic oncology at Johns Hopkins. And after that, I was in practice in Los Angeles at UCLA for a few years, for about 3 years. And then I moved out here to direct the surgical research and education program at the Division of Gynecologic Oncology. I have a very special interest in BRCA and hereditary cancer syndromes because I believe that it is one of the most impactful areas of research, because when you can prevent cancer, it's always better. It's always more advantageous to the patient. And also because it is a very targetable area that we can have excellent outcomes when patients unfortunately do develop cancers. So I spoke to Tracy earlier and we were brainstorming about what the best way to go about this lecture was, and it is ovarian cancer awareness. So my thought was that I would talk a little bit about ovarian cancer in general and what the statistics, the epidemiology, the things people need to know about ovarian cancer just as far as awareness goes. And then we can dive into a few topics. And then this can be completely interactive. Anything that you all want to talk about, I'm happy to discuss. I learn from these as much more, probably more than you will, because I learn what you're interested in. And so I always find that engaging with survivors and previvors outside of the clinic setting, I end up learning a lot more about what the patients in my clinic need and what they want to talk about. So I want to benefit from this as well by hearing what you want to know. So again, thank you for having me. I'm going to share my screen now. I have some slides, but again, this is completely informal. I want to answer any questions that you have. So we'll just, can you enable please the screen sharing? There we go. All right, can you hear me now? Can everyone hear me?
Yes.
Okay, perfect. All right, very good, thank you. So I figured I'd start by showing where I'm from. I'm actually Lebanese. I was born and raised in Lebanon. It's this giant country in the Middle East, this tiny little speck over here. And this is what it looks like. It's not really a desert. There's no camels, but this is where I grew up, and this is the university that I went to. It's called the American University of Beirut, and the slogan of the university really resonates in my mind a lot every time I am in practice, and it says it applies to cancer care. I don't think that was their intention. They were talking about it in education, but the slogan of the university is that they may have life and have it more abundantly. And I think abundance is in both quantity and quality of life. So I think this resonates a lot, and that's why I have this in my office to always remind us what this is about. This is where I did my training. It's at Johns Hopkins, and it was so long ago that I had much more hair back then. This was like 7 years ago. But a great place, and I know someone on the call is from Maryland, so we probably may have even crossed paths at some point. I was there for 3 years during doing my fellowship. So to talk about ovarian cancer and discuss the risk and the protective factors, essentially risk factors for ovarian cancer, having hereditary cancer syndromes and having a family history of ovarian cancer are probably the most impactful risk factors for developing ovarian cancer. But aside from that, age, obesity, and even though controversial, some studies point to fertility drugs being associated. The association is poor, and this is not very accepted as a universal increased risk. Protective factors, on the other hand, are the use of oral contraceptives. So patients who have used oral contraceptives as part of birth control for an extended period of time develop a long-term protection against ovarian cancer. Breastfeeding and having full-term pregnancies are protective factors as well, and having a hysterectomy and salpingo oophorectomy, meaning removing the uterus and the ovaries and the fallopian tubes, most importantly, are also protective factor. Interestingly, having tubal ligations, not just removing the tube, just having a tubal ligation is also a protective factor. So much so that there's actually one of the trials that we're opening up right now is in patients who have BRCA, who are not ready to have oophorectomy, to consider using removing of the tubes as a bridge towards oophorectomy. And we can talk about that if there's any interest in this a little later. It is a relatively rare tumor compared with other cancers. So in the United States, it's 11.6 patients per 100,000 women per year. So only about 1.3% of all new cancer diagnoses are ovarian cancer. But a woman's lifetime risk without a BRCA mutation or without hereditary cancer mutation is about 1 in 78. So that is the ballpark, that is the approximate estimate of someone is, if you take everyone, indiscriminate, not talking about family history or anything, just in general, if you have 80 women, one of them will develop ovarian cancer. And the way it presents is it essentially, the symptoms are very subtle, which is why this is a problem. It's difficult to diagnose early. A lot of other cancers present with signs and symptoms that in the early phase. So for example, endometrial cancer, women have postmenopausal bleeding, and we can catch it early because of that. But with ovarian cancer, a lot of the symptoms are symptoms that if I say these symptoms to 10 women, they're going to say this is what we deal with every month. So it's abdominal bloating, feeling full, not having a great appetite all the time, urinary urgency, fatigue, indigestion, constipation, pelvic or abdominal pain. And again, that's part of the difficulty, is that these signs and symptoms are very universal. And so it's very important to note that not everyone who has these symptoms will have ovarian cancer. Clearly, the majority of women have these symptoms as part of their normal life. The ones that are, when you look at the symptoms that actually led to a diagnosis, the most common ones that we see are bloating and increase in abdominal size. And so the ones that, other ones such as indigestion, nausea, constipation, they don't really alert women to present to their doctor because they're so common. And this was in a New York Times article that actually had quite a bit of, caused quite a bit of, I'll say fuss, if you will, because when this article came out, it was all over the news. CNN and all the news stations were featuring this article and discussing it. And so what happened was people would look at these list of symptoms and think, oh my God, I may have ovarian cancer. And so there was a huge uptick in the amount of patients that would want to be screened for ovarian cancer after this article. Again, it's very important to remember that many of these symptoms are common without ovarian cancer. So I don't want to under or overstate these symptoms. This is just what we find at the time of Unfortunately, the most of ovarian cancers are advanced at the time of presentation. This is what CT scan, for a typical CT scan that I see for women who present to me in ovarian cancer. You can see on the scan, and can you see my cursor? That are you able to see the cursor that I'm hovering? Okay, so you see all this here. This is all fluid. So this is called ascites. It's fluid that the cancer cells can produce. The peritoneal cells also can produce in reaction to having cancer, and that causes a large amount of distension. And if you look here, this is a big ovarian mass that's sitting here in the pelvis. So you can see how this is everything is being pushed up. You see the bowel is supposed to be all over the abdomen, but it's kind of pushed up by all this fluid to the upper part, and that's why a lot of the symptoms happen, especially the abdominal distension and the bloating. To evaluate these cases, we always the recommendation is to consult with a gynecologic oncologist. We do CT scans, we do labs to check what a woman's status is, and CA-125, which is a tumor marker, can be elevated in women with cancer. So 80% of women with ovarian cancer have it elevated, but unfortunately only 50% of women with stage 1 disease, which is early disease, can have CA-125 elevated. And also having normal CA-125 doesn't completely rule out ovarian cancer, especially in premenopausal women. It's not a good marker because in premenopausal women, the CA-125 marker can be elevated even without having cancer. So like I said, the majority of the stage of diagnosis is where you have distant metastasis at the time. And it's very rare that it's localized. So about 15% of cases are in the early stage. And as the more advanced the disease is at presentation, the lower the survival is. But I will say 80% of patients present in advanced stages. So this is the most common stage that we see and the one that we deal with most often. So there's developed quite a bit of expertise in dealing with these cancers. So, there's clinical challenges in ovarian cancer treatment. Our goal is to improve survival and maintain quality of life. First and foremost, that is the most important thing, increasing the quantity and quality of life. But other challenges are having earlier diagnosis, improving the understanding of different subtypes. And this is changing a lot. It used to be that you would look under the microscope to classify ovarian cancer. And while we still do that, right now we're not looking under a microscope as much to know our treatments, but more so we are looking at the molecular signature of the tumors. And so we need to improve our understanding of the different molecular subtypes of these cancers to be able to identify patient subgroups that may benefit from different treatments. So different ovarian cancers have different treatments. They're not all the same. And it's very important to be able to specify and identify the different types of ovarian cancer. So genetic testing is something that this group is very familiar with. The most important thing that I don't want to dwell too much, but the most important thing is that every single woman with ovarian cancer needs to be tested for BRCA. If anyone has had ovarian cancer, the first thing that we do is we test them, their genes or blood for BRCA mutation. So, and that's because if you only go by family history, you end up missing a lot of these BRCA mutations. Many patients with BRCA mutations may not have a family history of cancer. Traditionally, when we look at genetic syndromes, what happens is we'll ask the patient, for example, for other mutations like Lynch syndrome and whatnot, like we look at their family history and we try to stratify the risk of them having this mutation by looking at their family history. With BRCA, that's very important that we do that. I'm not saying that we should not do that, but it's not sufficient. So if a patient has had a personal history of ovarian cancer, then there should be universal testing in that population. And that is, we were discussing on one of the committees that I serve on, is going to become a quality indicator. So hospitals and doctors are going to be proverbially dinged if they don't test their patients with ovarian cancer for BRCA mutation. And I think it's very important because this is it has immense downstream effects. Again, of women with BRCA mutation and ovarian cancer, 44% may not have a family history. So if you only test the ones with family history, you're going to miss 44% of the mutations. And then when you look at the patients at their age of diagnosis, of women with BRCA mutated ovarian cancer, 71% are 50 years or older at diagnosis. So we tell, one of the things that makes us jump to think about testing is when we have a very young woman with ovarian cancer. So someone who's under the peak age. The peak age is in the 60s. But the majority of patients with BRCA mutated ovarian cancer have it at a higher age. So it's not to say that if you get it at a later age, then you're not likely to have a BRCA mutations. So something that's very important that has changed recently is the importance of both germline and somatic mutations. So to simplify this, there's two kinds of mutations that can happen. There's the ones that we inherit from our families, and these are called germline mutations. So the parent has the mutation, and then they pass it along to their child. And in that case, every single cell in that person's body will have that mutation. So their BRCA will be mutated in any cell. So if you test their saliva, their blood, their hair, any cell in the human body will have that mutation if it's a germline mutation that's been passed on from a parent. Now, the other mutation that now we more and more are understanding, and our understanding of this has grown tremendously in the last 15 years, are the somatic mutations. So these mutations occur after conception. So you are not born with this mutation. However, the mutation can happen de novo, or a new mutation can occur in one specific tissue, such that if someone has a BRCA mutated ovarian cancer, it's just the ovarian cancer that has a mutation. So if you test their saliva or their blood, you won't find the mutation. You need to test the tumor itself. And this is very important, especially I heard a couple of you speaking about PARP inhibitors and use of PARP inhibitors, and with the extension of PARP inhibition to beyond patients with just germline mutation, now patients with somatic mutations are going to have been shown to have extensive benefit from PARP inhibitors as well. Other thing that we're learning more is it's not just BRCA mutations that are important in somatic mutations. So tumor mutations in all these other genes, and I wish they would call them something more memorable than BRIP1 and ATM. But there's a whole a gamut of genes that act like BRCA. So we call those HRD, homologous recombination deficiency genes. And so we test the tumors for those because those patients also benefit from PARP inhibitors for treatment. Things that really important to consider when you look at the right, like you don't have to be a physician to realize that these slides look different, right? I mean, they just, the ones on the right, the pink, they're just different. And each one of these is a different kind of ovarian cancer. So it's very important that a cancer center has a dedicated gynecologic pathologist. For example, we have a gynecologic pathologist who did an extra training only in gynecologic cancers because they are able to discern between the different subtypes. And the reason we care so much about BRCA beyond also just knowing what a patient's risk is and how to treat a patient when she does have a cancer with a BRCA mutation. The other reason we really want to know who has a BRCA mutation and who doesn't is that cascade testing is immense. So it's an opportunity to prevent cancer. So testing family members of patients who do have a BRCA mutation has incredible advantages to prevent and perform prophylactic surgery on these patients. So the goal is to have a personalized treatment plan and for risk management. So for patients who have a BRCA mutation, clinical breast exam every 6 to 12 months starting at age 25, and MRI age 25 to 29, and MRI and mammography between age 30 and 75, and consideration of prophylactic mastectomy. But the other thing, as far as ovarian cancer goes, which is the topic of our talk, is risk reduction. So risk reduction with a bilateral salpingo oophorectomy, which means removing the ovary and the fallopian tube, has value in reducing the risk of ovarian cancer. And it's very important that I say reduce the risk and not eliminate the risk. And I'll explain that. So first of all, why do we need to remove the fallopian tubes? Why not just remove the ovary if it's ovary cancer? Well, actually, it turns out that the majority of ovarian cancer actually is not really ovarian cancer. It's actually fallopian tube cancer. Most of these cancers actually start in the fallopian tube. So any risk reduction surgery for ovarian cancer should include removal of the fallopian tubes to make sure that the risk is reduced appropriately. Removing the ovaries without the fallopian tubes is absolutely not sufficient for this. And what happens is when you do remove the tubes and ovaries, the risk of ovarian cancer then drops to what it is in the general population. So if a woman has a lifetime risk of 50% of getting ovarian cancer with a BRCA1 mutation, then what will happen is when she removes her ovaries and her fallopian tubes, the risk becomes 1 in 78, which is what it is in the general population. And that risk is for an entity called primary peritoneal cancer, which acts for all practical purposes like ovarian cancer. This is really important. It does determine the chemotherapeutic approach and what we do for treatment in patients who do have these mutations. So what are the challenges in getting genetic testing? For women with ovarian cancer, genetic testing is often not done at the rate that it should be. So it was discussed in 15% in one study that was by Childers. It just highlighted how often we miss. You would think that everyone gets tested, and at places that have protocols in place, like it's automatic. As soon as you get the diagnosis, you get the testing. But in a lot of other sites that are see a lower volume of ovarian cancer and they don't have these protocols in place, for various reasons, these get missed. Now, I wanted to talk about something, just to switch gears a little bit, about things that treatment issues that are very important. One of the things that really matters to me and to our center is to make sure that we have a holistic approach to treatment. And it used to be that people thought, oh yeah, it would be great if you took care of how you feel during cancer treatment, or it would be great if you took care of how you felt during, after your risk reduction surgery. But it's not just, you would feel great. There's actually data that shows that women survive longer and live longer if you pay attention to their mental health. So this is an example from breast cancer patients that the curves that you see in this slide are survival curves. So the steeper the curve is, the lower the survival. So if, for example, in these two curves, this curve has a higher survival rate. The only difference between the patients who are on this group and in this group is that the women on this group had psychological counseling with cognitive behavioral therapy. So the whole mind-body connection thing and the whole concept of the mind-body connection, it really is extremely important. And it's not just, it would be nice. This is essential to the care of any woman with cancer and any pre-vivor or any patient struggling or dealing with this. There's a lot that can be benefited from having cognitive behavioral therapy. And again, I can expand on that in the question, in the time for questions. I do want to just put some bullets out there, and then we can discuss in more detail what you are interested in discussing. This is in a different cancer, in cervical cancer, same thing. Your entire blood work, your inflammation, your whole system inflammation is completely altered by getting psychosocial testing and the psychosocial counseling with a psychologist and a psychiatrist, and that immense immune repercussions, and it helps your immune system fight the cancer better. One of the things that I wanted to also talk about, which is important, which is one of the novel approaches, not truly novel, but one of the, it has garnered more attention recently, is intraperitoneal chemotherapy. So heated intraperitoneal chemotherapy is where at the time of surgery for ovarian cancer, we place these catheters that you're seeing here, and we infuse chemotherapy directly into the at the time of surgery. At the end of the surgery, we remove the chemotherapy and remove the catheters. But the importance of this in BRCA patients is we know that women with BRCA mutations will have a higher response rate to intraperitoneal chemotherapy than patients without BRCA mutations. So this is of particular importance to this group because there has been data to suggest that that the benefit of intraperitoneal chemotherapy is the majority of the benefit is in women with BRCA mutations. And these are the curves that show that. This is not in BRCA, this is in all comers. You can see that patients who have HIPEC is heated intraperitoneal chemotherapy. Patients who do receive HIPEC do have a higher survival in the upfront setting, but also in the recurrent setting. And I think this is, for me personally, when I have a BRCA patient, I'm more likely to take them to the operating room if they're a good candidate and perform heated intraperitoneal chemotherapy if they're a BRCA patient. A couple words on screening. Unfortunately, screening for ovarian cancer doesn't work. A big part of this is because the cancer starts in the fallopian tube, and most of the screening modalities focus on looking at the ovaries. These are two trials that look at screening, different types of screening: ultrasound, CA-125, sequential CA-125. And overall, the detection rate, the meaningful detection rate, is extremely low. We're unable to catch these early enough. And actually, in a lot of cases, it causes harm because you'll end up finding cysts and other things that cause anxiety, and they're usually benign, but you found it. Now, what are you going to do? You're going to have to operate on it and cause surgery and cause stress for the patient, and it doesn't increase the detection of early cancers. This is what I was talking to you about earlier a little bit with the fallopian tube. So what we've been able to identify recently is something called STIC, which is serous tubal interepithelial carcinoma. And STIC lesions these are lesions that occur in the fallopian tube, and those are the precursors to ovarian cancer. And this is the reason why a lot of these cancers are not detectable early. So I want to pause here because I don't want to, there's so much to talk about with ovarian cancer, and I do want to discuss what's actually interesting to the group. I know Tracy was interested in me to talk a bit about hormone therapy after having a prophylactic removal of the fallopian tube and the ovaries. And I think someone else wanted to hear more about PARP inhibitors. So if it's okay with you all, we can do the rest of this in an informal way and just have the discussion so that it can be interactive and I can benefit you in the things that you actually want to know about. Does that sound okay?
Perfect. There is one question that
Yeah.
I am finding that the HIPC in New York is on a clinical trial basis only and only with reoccurrence.
HIPEC?
Yeah.
No, yeah. So there's definitely HIPEC, again, for everybody. HIPEC is heated intraperitoneal chemotherapy, and that's true in New York. One of Sloan Kettering, a lot of my colleagues who work there, they have been leading a lot of the work in HIPEC. However, it used to be in the clinical trial setting. We have had one major publication and a bunch of other publications, but at least one major publication in the New England Journal of Medicine, and that's the #1 journal for medicine, that shows that actually HIPEC has a survival advantage. And since that time, it is no longer only on clinical trial. It's now it's an acceptable standard of care. And for those of us who believe in it, as we actually perform it.
So Jennifer has a question. Go ahead, Jennifer.
Yeah. So I'm actually Melissa. For some reason, I'm under my sister's name, but my questions actually do pertain to my sister, Jennifer. So yes. She and I are both BRCA1 positive. We both had prophylactic. She had a total hysterectomy. I had a supracervical hysterectomy. She had hers 2 years ago. I had mine in February. Mm-hmm. So last week she was diagnosed with the pathology is a little bit unclear, but basically says either primary GYN or primary peritoneal. We're assuming it's been 2 years since her hysterectomy. Her pathology at that time was clean. We're going to assume it's primary peritoneal. So we called Sloan to make our appointment. We're scheduled next Wednesday. what I'm finding a little baffling is that after the clinical team discussed her case, they scheduled her with a medical oncologist and not a surgical oncologist. So right now, the mass that they're seeing is in her omentum. And I'm a little bit confused by that, but because as I understand it, the standard of care would be at her age to perform surgery followed by chemotherapy and then PARP inhibitors.
So those are all, first of all, I'm really sorry for what you and your family are going through.
Thank you.
I really hope she has a speedy recovery. I will say that, every clinical situation is very different. So it's impossible for me to specifically say. However, the decision to do chemotherapy first, the question is more, do you do chemotherapy first followed by surgery and then more chemotherapy? Or do you do surgery first and then chemotherapy? So those are two different strategies for treatment of ovarian cancer. Patients, for a multitude of reasons, depending on the way their disease looks, depending on the distribution of their disease and how radical the operation would need to be, would get triaged to one of those two algorithms. Either way, surgery is an essential part of the treatment, but sometimes we do chemotherapy first to minimize the amount of tumor that's there to make someone more surgically resectable. The goal of surgery is to get to an R0 resection. R0 means no residual disease. And so sometimes the disease burden is so extensive that to achieve that, you would require an extremely radical operation, removing a lot of bowel, removing a lot of colon, removing part of the lip, and that sort of thing. And in those cases, we do chemotherapy first. I can't speak specifically to what your sister is going through. However, that's often what happens. And then the second thing is, gynecologic oncology is unique in that as gynecologic oncologists, we do both medical and surgical oncology, but there are certain institutions that have split that. So Sloan is one of those places, and there's ways there's benefits to either way. Like, I'm not saying that one way is better than the other, but there's at Sloan, the gynecologic oncologists practice as surgical oncologists, and then the medical oncologists do the chemo. The final thing I want to tell you is that there has been multiple, at least 2 randomized controlled clinical trials comparing upfront surgery followed by chemotherapy to chemotherapy, then surgery, then more chemotherapy. And those have found equivalent survival. So there's no benefit of one over the other. But the fact that she has the BRCA mutation, the most recent study that came up, which is called the SOLO trial, has shown that patients who have the BRCA mutation, when after surgery you put them on a PARP inhibitor, the benefit was so high that the endpoint of the trial wasn't fully met. So it was, they gave the analysis at 39 months. Like, there was a 39-month advantage with adding PARP inhibition maintenance after treatment. And that's in patients, in that study, it was in patients with BRCA mutations. So there's, the future is bright, and the advances, especially in this field, should lead us all, and you and your sister, to be very hopeful about that.
And I was a little surprised that, between Sloan and I forget who else it was, I want to say NYU Langone, they still consider the HIPEC clinical trial basis only. However, Stony Brook, which is right near us, they do offer it. But from what I understand, it's only on like a stage 4 or a reoccurrence basis. And here, again, this is why I was a little confused by Sloan's scheduling with the medical oncologist. Her disease seems quite limited and quite early. So, hopefully there's just something a little bit lost in the translation there. Or maybe the other question I had actually was, somebody had mentioned to me the intraperitoneal chemotherapy, not like HIPEC, but I guess an injection. What is that?
Yeah, so there's heated intraperitoneal chemotherapy is only done in the operating room. There is another way to give chemotherapy, which has in ovarian cancer, which is to put the catheter. You know how someone can get a port to get chemotherapy in the vein? You can put that same port, but instead of it going into a vein, it goes into the abdomen. Okay, and so you can instill the chemotherapy directly into the patient's abdomen. And so the idea is that the concentration of the chemotherapy that gets in contact with the tumor is much higher. So I was someone who did a lot of intraperitoneal chemotherapy for a very long time. The issue with the intraperitoneal chemotherapy has always, the reason why the rest of the country didn't take it, it was only at big centers like Johns Hopkins and Sloan and those kind of places that did intraperitoneal chemotherapy, is it requires a lot of expertise and knowing how to troubleshoot the catheters, and it's pretty toxic. So actually on the original trial, that one of the trials that showed it is that 80% of patients weren't able to complete all of their IP chemo, intraperitoneal chemotherapy. So we modified the regimens and then things got more tolerable. Unfortunately, there was a very large clinical trial. It's called GOG 252, which was presented, I think it was 2 or 3 years ago at the Society of Gynecologic Oncology, that showed that there was no benefit to intraperitoneal chemotherapy over traditional IV chemotherapy. So a lot of people abandoned the IP chemotherapy. However, I will say, this is something that I was alluding to earlier. In the original study that showed benefit with IP chemotherapy, when they did subgroup analyses, it showed that the majority of the benefit was in patients who had BRCA. So I personally still do IP chemo for patients who have BRCA if I don't do HIPEC. It's one or the other. And a lot of centers are now doing HIPEC as a standard of care after that big clinical trial was published, because we have great level 1, highest level of evidence data that shows that it's safe and that it's has a survival advantage.
Okay, so you still do the HIPEC even as like a first line of treatment?
Absolutely.
Okay, thank you.
So we have a question from Amy.
Yeah.
I'm interested in your thoughts on the PARP after PARP. I've heard that platinum chemo, there are some thoughts that the PARP pathway is reset.
That's a really good question. That's a really good and very actually advanced question. So whoever posed that question has been doing their homework. So good job. So the PARP after PARP is very interesting. Is a very interesting concept. It's not so much that there's a reset. So the idea for the rest of the group in traditional chemotherapy, like let's say someone gets carboplatin and they progress while they're on the carbo. Okay, so I'm not saying the cancer went away and it came back. I'm saying someone's getting carboplatin and then they progressed while they're on it. Okay, so that's called platinum resistance. So the idea is that once you progress on a chemo drug, you can't use it again because the tumor is resistant to it. So the PARP after PARP is, let's say someone goes on maintenance PARP for a long time, and after that they progress, and you treat them and you get them down to no residual disease, or they get into remission. Can you use a PARP inhibitor again after maintenance? That's the question. And there are some data that have been presented at annual meetings. It was presented at ASCO, which is Annual Society of Clinical Oncology, in, I think it was 2019, where there was a paper that was presented there showing that there is benefit to doing PARP after PARP in selected patients. So it's not that if someone was on a PARP for a while and they failed it, then you put them on another PARP right away. It's in very specific situations. And I will tell you, we do it. We definitely do it in those specific situations.
So that was my question. I kind of had one follow-up question, if that's okay. If not, I can.
Sure, absolutely.
So,
I'm here all night. We can, we can open a few bottles of wine and have drinks, make a night out of it.
like a good
So
plan.
I cleared out my evening because I'm really free all night, so I can take all the questions in the world that you want to ask. Please go ahead.
So I'm on Lymparza. I've been on it for about 10 months. I work in the PARP industry, so I kind of have a little bit of an advantage. I work for a company.
Okay.
I don't work for who I take drugs from, so I don't talk too much about it.
Well,
But
don't tell your employer though.
they don't know. But I guess I was surprised though. Like I'm about 10, 11 months out, and my numbers are starting to climb, which seems really surprising. Like I really expected, just looking at the data, I would have thought of like 18 months to 2 years based on just what I know statistically. What is it about BRCA people that sometimes are recurring so much earlier? I just think I was just really surprised at a 10-month time point to start to see a recurrence.
So yes, you are right that in many times the recurrence can be longer. There are many different factors that are involved with having an early recurrence. But the truth is that even with an earlier recurrence with BRCA, while it's very distressing, you still, as long as it's more than 12 months since the end of treatment.
10 months.
10 months. So sorry, the 6 months is what we define as platinum sensitivity. So as long as it's more than that, then you're still platinum sensitive. And so the treatment, again, with platinum can be expected, hopefully, to get, can get remission again. The other thing to say in that situation is that you can't only go by numbers. So the numbers go up and down. And actually there was a study, the author was Rustin. This was in 2000. It was an old study, 2012. Yeah, it's been 8 years since that study, where they actually started treating women only based on their CA-125 before they developed symptoms and before they could see anything on a CT scan. And so actually what turns out is there was no benefit to doing that, because just because the number, you treat the patient, not the number, right? So the numbers can go up for many different reasons. When you monitor them, you definitely pay attention when it increases, but you don't know when the recurrence will happen, right? So if the numbers start to go up, it's a harbinger that, hey, we need to pay attention. We need to start getting scans more frequently, or take a look and do exams. But it doesn't mean that, it could be that it's 12 months. It could be that it's 16 months. You can't really, CA-125 is not as powerful a predictor. I think we put too much emphasis on it. It's very important. And when it's consistently climbing and by large numbers, like not from like 30 to 32 to 35, like when we say it's like from 50 to 100 to 500 to, when it's that kind of increase, that's where it has some power in detection and it has clinical meaning. But there are aspects of BRCA that we don't fully understand yet. Why do some patients have more durable responses to PARP than others? And there's actually really fascinating science on PARP inhibitors that they're actually not all the same. So one PARP may have a different response than the other too. So that goes also to PARP after PARP, that if you do a second PARP, I would recommend, I can't give any medical advice, just to be very clear, but in hypothetically, I would recommend using a different PARP inhibitor in the future. And I would, even though you were saying it was, if a patient had a 10-month only interval. After I get them back into remission, I would use a PARP again, because if you're BRCA mutated, there are different mechanisms of actions, different degrees. And I don't want to get too technical in general, but there's PARP trapping, and there's many different pathways that PARP inhibitors work. And actually, like there was 2 studies that came out in the last year that showed that actually you can even combine a PARP inhibitor with Avastin for maintenance. And those showed benefit. Like there's definitely a lot of science happening. And a lot of advances happening. But to be very honest, we don't know exactly why some patients have durable responses to PARP and some patients don't. Or at least I don't know, but I don't think anyone knows.
Thanks.
Let's see.
And I wish you all the best, Amy.
Next question. Is it more difficult to detect ovarian cancer when a patient has been diagnosed with PCOS?
That's a very interesting question. PCOS, there's many different ways that patients get called that they have PCOS. So PCOS, the appropriate definition of PCOS is a syndrome, right? It's not just having cysts on the ovaries. It's a syndrome that may include having cysts on the ovary in a certain fashion, but also having anovulation where the patient's not ovulating. And then the second thing is having hyperandrogenism. So it's like increasing the patient's like having a higher testosterone level. So it's hirsutism, and in severe cases, it can be clitoromegaly, where the clitoris is enlarged, and the deepening of the voice and that sort of stuff. But that's in extreme cases. But in general, like more subtle signs of hyperandrogenism. So that being said, so traditionally we thought ovarian cancer is considered a disease of what used to be considered the disease of incessant ovulation. So women who have regular ovulation, which is very, very frequent, are at increased risk, right? So that's why we think birth control pills are protective, because they stop the ovary from ovulating. So someone who has been on birth control for 5 years, they have less ovulation in their life. So if 5 years, that's 60 less cycles, right? 60 less ovulation events. So those patients have a protective effect. So with PCOS, the increased risk is of endometrial cancer if the cycles aren't regulated, because you have all this estrogen, because you don't ovulate, because a person doesn't ovulate, then it's always estrogen coming on the uterus, and it can increase the risk of endometrial cancer. So it's very important for women on PCOS to actually get progesterone, be on birth control pills or a Mirena IUD or something to protect their uterus from having uterine cancer. And then one of the benefits would be of being on birth control pills is it'll do that, but it'll also help protect you from ovarian cancer. Is there a more difficult time? And I'm sorry, that was a very long answer for a very simple question that you asked me. Your question was, is it harder to detect ovarian cancer with PCOS? And the answer is no. It's the same.
That's okay, because you're touching on a lot of things that that go into that question that I had anyway. So thank you for that.
You're very welcome.
Because
but yeah,
I just wanted to bring up too how, you know, your uterine lining tends to be thicker with PCOS, correct? I mean, that's what I had found in researching online, that your uterine lining tends to be a lot thicker because your menstrual cycle is extremely irregular, at least mine is. And then that can also cause, I was just wondering if there was like a correlation with that, and then on top of that with BRCA, just because if, you know, I'm thinking, okay, well, if ovarian cancer kind of goes into, you know, where it can start in the tubes, then there can also be an increase in cervical cancer, correct? And gynecological cancers in general.
Mm-hmm. Well,
right?
actually, with PCOS, with PCOS, there isn't the relationship with cervical cancer. That's for sure. There's no relationship with cervical cancer, and the major relation is with endometrial cancer. But the important, so if you want to think of it, is to really make it simple, is if you think of the uterus, estrogen is like building blocks, right? It adds building blocks to the uterus, and then when you ovulate, there's progesterone that comes, and that's like the cement that holds the uterus together. And then when you ovulate, if no fertilization occurs, the cement goes away, and then you have menses, and then restart. So patients who have PCOS keep getting this estrogen. So you're putting more and more building blocks, and you're never getting the progesterone, which protects the lining. So eventually what happens is you're putting building blocks with no cement, part of the wall is going to fall down, so you have irregular periods. And it's the constant estrogen is what stimulates the risk of uterus cancer. But being on a method of birth control or something, it's very easy to protect someone from getting uterine cancer when they have PCOS. All you have to do is either regulate their cycles or give them progesterone to protect, you know, someone, for example, people who are actively trying to get pregnant, you don't want to put them on birth control pills, right? But you can give them cyclical progesterone, and a general gynecologist can do that. So it doesn't require a high expertise or anything like that. A regular general OBGYN, nurse practitioner, PA, they will put you on a birth control pill or put a person on a birth control pill, and it'll help prevent many of these. And added benefit, 80% reduction in some studies of ovarian cancer when you're on 5 years of birth control pills. So it's a win-win.
Oh, wow. Okay. I was just curious if there was like a, you know, where I would be put in a situation where they would recommend to go ahead and have the risk preventing surgery sooner than the typical average age to do so.
So in women with BRCA mutations, we recommend risk reduction surgery depending on which mutation a person has. So in a BRCA1 mutation, it's earlier. So we say by age 40 or completion of childbearing. So if someone completes their childbearing at age 35, then we would recommend it done then. The fact that you have PCOS will not, but the fact that you have PCOS does not impact that at all. So when someone would recommend that. And again, this is all, we're discussing science. I'm not allowed to give medical advice or anything on these platforms.
I understand.
But that's, and with BRCA2 mutations, the recommendation can be delayed till age 45 to remove the tubes and ovaries. And this is something that I actually feel like I find very, very important to discuss. And this is actually also a research interest of mine. And this is something that Tracy and I were talking about today, which is when you're young and you get your ovaries removed, that has a lot of side effects, right? So you, I don't need to tell you all, but there's two kinds of menopause. There's natural menopause, which occurs depending on your race. Like Black women have menopause later than white women, but it happens gradually. So the estrogen levels reduce slowly, and your body has time to adjust. Once you remove the tubes and ovaries, that's called induced menopause. It's surgical menopause. It's, pow, you all of a sudden had estrogen that was up here, and then remove the ovaries, and boom, the estrogen's all the way down. And so the symptoms of menopause are dramatically worse when you do that. So, and when I talk about symptoms, I'm talking about hot flashes, depression, anxiety, mood swings, vaginal dryness, genitourinary syndrome of menopause, which is burning when you pee, or problems with urination, low libido. Those are symptoms. The other thing is that you have a higher risk of osteoporosis when you don't have estrogen, right? So if someone, after 10 years of not having estrogen, you need to do DEXA scans, and you need to pay attention to that. More importantly, is you have a higher risk of heart disease. So when you look at men and women, women have a much lower heart disease rate than men until menopause, and then the rates kind of become the same. And then there's also data that shows that removing ovaries early without doing anything about it, and I'll tell you, the good news is there's something to do about it, so I'll get there. So removing ovaries early without supplementing with hormones can cause earlier cognitive impairment. So as we get older, there was one study that shows there was a higher rate of dementia or memory loss in patients who don't have replacement. And that's the least strong one of all of them, right? So that was one study, but it was a study that was there. But the cardiac issue and the bone issue is extremely important. So a lot of medical oncologists and gynecologic oncologists feel that unknowingly don't recommend hormone replacement therapy. And this is something that I just published an article on for the Society of Gynecologic Oncology, and I sent it to Tracy because we were talking about this today, and I'm sure, Tracy, you can share it with the group, about the safety of hormone therapy after removing the ovaries for BRCA patients. So the number one thing is, as long as someone has not had a breast cancer, you can use hormone replacement therapy, and you should use, not you can, you should use hormone replacement therapy to protect the bones, the hearts, and to improve the symptoms. And actually, so the reason people are afraid of it, they say, oh, well, what if it increases your risk of ovarian cancer? Well, actually, there was a study that in patients who have had ovary cancer, and I'm not talking about they haven't had it and we're worried about prevention, they've already had it, and you give them hormone replacement therapy, they have a higher survival rate than the ones who didn't get hormone replacement therapy. So it's actually beneficial when they have, in that sense. That's a phase 3 randomized controlled clinical trial. Second thing, in women who do not have a history of breast cancer, and you just BRCA patient, got her tubes and ovaries removed at age 35, and you give them hormone, well, we have studies now. So we have studies with long-term follow-up. The good thing about removing the uterus at the time of the ovaries is we can give you estrogen alone. The problem in the PCOS patients is that they have estrogen that can cause uterus cancer, right? So in young women who have not had any breast cancer, when I do a risk reduction removal of the ovaries, I also remove the uterus, because what can I do then? I can give her estrogen alone, and that does not increase your risk of breast cancer at all. Actually, in one study, there was a non-significant decrease in the risk of breast cancer when you gave estrogen alone. So we know it's completely safe in women, as long as, you know, there are contraindications to hormones, like someone who's a heavy smoker, someone who has a history of blood clots, someone who has like really bad migraine with aura, not just a headache, like a specific type of migraine. Those patients should not get hormone replacement therapy. But if you don't have those things and you haven't had breast cancer and you got your ovaries removed, do yourself a favor. You should be on hormone replacement therapy. And this is not like my opinion. This is science. It's published. This is like, I just published this on behalf of the Society of Gynecologic Oncology. So it's not like, this isn't someone's opinion. So, and then I'm sure Tracy can share the publication with you. There's a whole section only on BRCA patients actually in that publication.
I'll share it on our social media. You guys can see it. I'll probably post it tomorrow. But I have a question as you're talking, like with migraines and auras. From what I understood, what I was told is that if you have aura migraines and you're not on hormones, going on hormone therapy would help those headaches.
Well, it depends what kind of aura it is, right? So, and it depends how severe and how regular the migraines are.
Okay.
So the reason we get concerned about aura headaches is if it's a true aura. And by aura, for everyone, if anyone doesn't know what an aura is, it's like where you know you're going to get the headache before you get it, because let's say you start getting flashes of light, or your eye twitches, or you start to smell a weird smell, and then you get the headache. So that's your aura, is what you can see, what you can feel before you get the headache. So the concern was, my voice loud, really low there?
It's okay. We heard.
It's okay, yeah. It's weird to hold my phone up like this to the, but this is the only way I can get a microphone going. Sorry. But anyway, yeah. So the thing with the auras is, we think the auras are vascular events. So like, the reason someone gets an aura before a migraine is because there's a vascular event going on, like a contraction, a constriction of a blood vessel, and there's concern that you can, if you give estrogen to someone with an aura, you can increase the risk of having a stroke. Now, it depends on what kind of aura it is. Like, a lot of times, like, oh, I know I'm going to get a headache. Well, it's actually my head starting to hurt. It's not a true aura. It's not like I smell like dandelions and then I get the headache, right? Or I get flashes of light, right? So it really needs to pay attention into what exactly is the aura. And it's always something that we can discuss with a hematologist, because again, the risk of not being on hormone replacement therapy when you're that young is very high for your bones and your heart for the future, and your quality of life and your sex life, which no one talks about enough. Oh my God, no one talks about this enough. I don't understand why. I'll tell you what, they talk about it a lot with prostate cancer. Like, when it comes to men and their prostates, all they talk about is their sex life. But it comes to women and removing their ovaries, like, oh my God, we can't talk about it.
We have a talk. We have a talk coming up, sex and mental health, with one of your physicians, Dr. Pozo.
Yeah. There's a really good book written by a gynecologic oncologist. It's called Sex and Cancer. And but the other thing with, it's really hard to have the urge or the motivation or the wantingness of having to have intercourse when the hormone replacement therapy is not there, because your body's telling you that you don't want this, right? So it's not like just a psychological thing. But in patients who are not candidates for hormone replacement therapy, it's very important then to pay attention to those things. So when it comes to sexual health, there are many things that can be done. When it comes to bone protection, there are many things that can be done. We need to make sure we screen. We make sure, like, in the general population, we don't do a DEXA scan until you're 60. If you've had your ovaries removed and you can't get hormones, then you need to start doing it. Yeah, you got to do it. Like, sometimes I even do a baseline. I saw a really good question here. Is there very important question? There's a lot of questions.
Wait, there's a couple questions.
Yeah, go ahead. I'm gonna let you go first.
You want me to read it? So I have heard mixed info on birth control and BRCA. Is it still considered protective? I have a 15-year-old daughter and not sure if she should start on birth control. She would not test for BRCA for a long time.
So in general, when we know someone has, so I get this a lot. I get a lot of patients who are BRCA, but they're very young, right? So 20 years old. We're not going to remove their ovaries. So what can I offer them to reduce the risk of ovarian cancer? It's the birth control pills. So it's kind of, there's question marks about, hey, can you do, like, is it safe to do the progesterone in someone with BRCA? Now, the data is all over the place, but there's nothing definitive when it comes to oral contraceptives. There's nothing definitive that says it increases your risk of breast cancer, but at the same time, there's a lot of good data that it reduces your risk of ovarian cancer. So in general, for this hypothetical patient who's 15 and may have BRCA, that's what I do with my patients who are young. I put them on birth control pills to protect them.
Are there any specific...
And also, very importantly, do the age recommended screening, right? So that's the other thing. That's the other reason you would want to know, is because you would start doing the mammograms and the MRIs and that sort of thing. So that will also add reassurance to.
Are there any
type
of birth control you would recommend?
Sorry, go ahead.
Sorry, I was just saying, like, as far as like types of birth control, I'm old and out of touch. Like, is there any articles you could point to, or certain types studies are recommending, like, types of birth control that are better than others?
No, and the truth is, it's whatever works for you the best, right? So I'm a very simple person, so I like very simple birth control pill, like the 1 dose, low dose, that's what I like. But you don't want to go to the lowest dose, because you don't want to just prevent pregnancy with this. You want to inhibit ovulation. So essentially, the truth is, there's no data that one's better than the other. But just intellectually speaking, I don't go for the lowest dose. I go for the next higher up. Just to be very clear, I don't have any science to back up what I'm saying as far as one better than the other. But this is just like, it makes sense. I'm trying to inhibit ovulation. I'm not trying to prevent pregnancy only. So I want the slightly higher dose for it to inhibit the ovulation. But again, just to be clear, the guidelines are any birth control. And there's all these triphasic, monophasic, 27 off, 4 on, it doesn't matter. The point is you want to inhibit the ovulation and prevent, that's what reduces the risk.
So next question, what screenings could be done other than a CA-125 post-hysterectomy to watch for primary peritoneal in BRCA1? Does the prophylactic hysterectomy reduce breast cancer risk?
So, and then there's a estrogen only or with progesterone. So these are great questions. Like all the questions I've gotten so far, you guys are really well informed. So first of all, in the general population, we don't screen people for ovarian cancer, correct? So we just don't. So once you've had your ovaries removed, your risk of ovarian cancer is the same as the general population. So we don't screen you either because it doesn't help. It has not been shown to improve the detection rates, but more so, the worst thing is it increases your anxiety levels. And the thing is, your CA-125 is going to fluctuate, especially in young women. So you can get the flu and that'll bump up your CA-125. You can get appendicitis. You can get, if you get your CA-125 the day after the day after, I don't know, you have like a diarrhea, then that can increase. Anything that irritates the peritoneal lining can cause a small rise, right? So we don't recommend CA-125 screening for someone who's had removal of the ovaries. I just want to be very clear when I say, I know that that's what you mean, but just for everyone else, when you say post-hysterectomy, when it's really the ovaries that matter the most. The uterus, a lot of times we don't, the only reason I remove it is to reduce the risk to be able to simplify the hormone therapy. There is one study that showed that in BRCA1 patients, there may be an increased risk of uterine cancer, a specific subtype called uterine serous cancer. One study. And because of that one study, a lot of people are now just removing the uteruses. And I think, if you're not going to use it and there might be an increased risk, there's no harm, especially if it'll simplify your hormone therapy. So that goes into the next question, which is what kind of hormone therapy do you recommend? And so that's what I would recommend is the estrogen alone hormone therapy on the condition that you've had the uterus removed, because we know that that's safe in BRCA patients. The big study that had on hormone therapy in BRCA patients included estrogen and estrogen and progesterone. But then when they broke it down, and this was not high quality data when they broke it down because it was unplanned analysis, there was an non-statistically significant increase in the breast cancer when patients had the progesterone. So, and that makes sense. So we know that progesterone may increase your risk of breast cancer from the WHI study, the Women's Health Initiative study, even in non-BRCA patients. So I really do prefer to do the estrogen alone because I know it's safe, and that's why I would recommend the hysterectomy for someone like that. And then the final thing, does the prophylactic hysterectomy reduce breast cancer risk? And I know, again, that you mean the oophorectomy, not the hysterectomy. Yes, it does. The removing of the ovaries significantly and dramatically reduces, not eliminates, very important, not eliminates, but dramatically reduces your risk of breast cancer. Because think about it, you're not having that progesterone. Same thing.
Perfect. Does anybody else have any other questions that weren't typed in the chat or asked? You guys can raise your hand or just unmute yourself and ask any questions if you want at this time.
Oh, I see one in the chat. Recommended cutoff for HRT. So the natural age of menopause is 50 to 55. I wouldn't recommend someone be on it forever, but I would at least want to get them to that. Estrogen still plays a role up to age 65, but putting someone on hormone replacement therapy for a long time beyond those ages is associated with increased risk of stroke and cardiovascular events. So I would say roughly 50, 55, but not beyond that. So it's just to get you to that natural menopause age. What I'm more interested, what really matters is to not, patients who are under 50 to not have, it's for the cardiac and the bone. Now, if someone's having really horrible symptoms at 55, you're not going to withhold it from them. But it's very important I understand that there may be an increased risk with use of hormone therapy at a later age.
What is the typical dosage for estradiol patch for someone who had a hysterectomy and oophorectomy at the age of 35?
So the truth is, there's not a recommendation, a strong recommendation. Traditional wisdom is use the lowest dose for the lowest amount of time, but that is for postmenopausal women. For premenopausal women who are very young at age 35, I would start with the middle dose and even go up to the higher dose patch, because you want to make sure you're replacing the estrogen. You don't, it's different than when these patches were developed for postmenopausal women, and that's where the doses come from. So it can be a patch, it can be a pill, but like I have someone right now who's actually a BRCA patient who I started her on the middle dose and it wasn't enough. So we doubled up and we're going up to the higher dose. Again, it's safe as long as you don't have contraindication. And then it's also very important for bone and heart protection. So whatever the true answer is, whatever it takes within reason. But if your symptoms are controlled on the lower dose, then you can do that. But I would say for most young women, for a lot of young women, and I don't know of a study that breaks it down by age, but for a lot of young women, the lowest dose doesn't cut it. But you try. It's a trial and error thing. So
perfect. Does anybody else have any other questions?
I have a crazy one.
Go ahead.
Awesome. I love crazy ones.
You always gotta end the night good, huh?
I mean, there's always, that's why I like coming when I can to these meetings, because then you learn something from your personal experiences. About 37, 38, that's when we started to try to have kids. And we found out that we couldn't, and I lost an ovary and two endometriosis, which was also an issue on when I was trying to do IVF. After I had my son, I did a hysterectomy, and maybe 2 years after, I was diagnosed with breast cancer. Now, you mentioned the estrogen treatment if you have lost an ovary or two. I think that's where maybe I got confused. But if I am breast cancer patient, not BRCA, I hope, I don't know, what would be the best thing that I should do in that matter? Because
yeah. So yeah, that's a really good question, Mary, because it's I can't state this enough that these recommendations are for someone who has not had breast cancer. Okay, if you have had breast cancer, you should not use estrogen, but that doesn't mean you should ignore those things that we're talking about. So when it comes to heart disease, you should absolutely watch the weight, do your exercise, don't smoke, take your aspirin if your doctor recommends, keep your cholesterol low, pay more attention than anyone else. With my hands, I just punched it out. Pay more attention than anyone else in the world does to that stuff. When it comes to your bones, make sure your primary care doctor, hey, listen, man, like I got my ovaries out. You should be checking my bones. Like, we're not going to wait till I'm 60. It's going to be 5 years after I get my ovaries removed, and then every 10 years after that. And then there's medications that are non-estrogen based that can protect your bones, but we got to find it. So this is just because you can't use hormones, it doesn't mean you can't protect yourself from all the side effects of having your ovaries removed. In the past, it was very different. Like, there was no such thing as a hysterectomy without taking out ovaries. It was part of taking out the uterus. Like, people would just take out the ovaries, right? I think it's in the last 10 years that people understand that, oh, the ovaries have a lot of non-hormonal impact on the body. Well, they are.
That's the thing. My doctor told me, I'm not going to take your ovary out because then that could cause you issues. And I was younger. But one of the other reasons why I wanted to do what I did was because around that time I had a friend that had endometrial cancer. And then I had endometriosis. I'm like, man, God forbid that happens to me. Let me get rid of what I could get rid of. So that's why I did the hysterectomy. But he said, I'm not taking the ovary. So in a way, I'm glad, but I don't know if it's maybe a cost, which I may have to go to my doctor anyway. But like, I still feel like if I'm going through a cycle and everybody tells me, oh yeah, that's a normal thing, but the pain is ridiculous. So it's like having the issues that I have with my period all over again every month, even though I don't see anything.
Right, right, and it's very difficult when someone's had a history of breast cancer to be able to give them hormones, but there are other options that can be given to shut down that ovary if you didn't want to get surgery to get it removed. And again, I can't give medical advice, but there are shots like Lupron that can completely shut down the ovary and stop. And those are not hormones. They're the opposite. They shut down the production of hormones from that ovary. But again, if someone's had a history of breast cancer, then I would not recommend any hormone therapy, even if it's ER and PR negative or any of that, right? So people think like, oh, if it's estrogen negative, I can do it. No.
Thank you.
With no more questions, I kind of want to end the night on one note before I thank Dr. Sinno. He brought up a really good point about DEXA scans, ladies. I know it's not spoken enough about, getting DEXA scans, either baseline or follow-ups. But I'm a true candidate, and I unfortunately have developed severe osteoporosis and now have to go on medication. So I strongly suggest to all of you to be your own advocate, either if you're taking preventative measures or you have breast cancer or ovarian cancer. Just make sure you have your baselines and you make sure you go for your follow-ups, because now I'm learning a year later, like I've gone to -4 and my bones, it's really affecting my hips and my knees. So I just want to suggest to all of you to make sure you get that screening. You can go to your OBGYN, you can go to your internist, anybody can write a prescription. It's an easy scan. Just make sure you get it and watch your bones. Also we've spoken about cardiac health. We've had a cardiac oncologist actually come on. Just make sure we follow up with all of our aftercare of our surgeries and our procedures, because it's so important and often it's so forgotten. I don't want it to ever get too late for somebody where they suffer more than we need to. No matter what our journey's been, we've been through enough. So just follow-up care, especially gynecological care, is so imperative. I've learned that, I didn't know originally I had to still see my gyno after my hysterectomy. I had no idea. And then recently we had a call and I was like, oh, wow, nobody ever told me that. So the follow-up care is so important. And I just could not be a bigger advocate of pushing that to all of you that are on the call. I'm sure Dr. Sinno, if you have anything to say, I'd really like to.
Yeah, absolutely. Listen, there's this thing that cancer care is not like it used to be, and preventative care should not be like it used to be. In the past, it was you give someone chemo or you do their surgery and then that's it, you've done your job. But that is not true. That is not true. So I'll give you an example. Someone, when I see a patient, before they even start the chemo, they see a psychologist, a nutritionist, someone for acupuncture, physical medicine. Like, all these things are really important. That's before treatment. After treatment, it's the same thing. So after you get your treatment, there should be a full plan. So we call these survivorship plans, okay, that include all of these things. They're so important. So a lot of cancer centers, they have survivorship clinics. We have those at our institution. I'm sure many of your institutions do. And for those of you who are institutions that don't, you can get a lot of survivorship plans from either your colleagues who are on this call or in this group, or also from centers that do have them. They're downloadable packets that tell you, hey, listen, you've had this cancer and you had this surgery, so this is what you need to pay attention to. You've had your ovaries removed, you need to check your bones, you need to check your heart, you need to make sure to exercise to keep your muscles strong, so you keep your bones strong, and get your DEXA scans and whatnot, So definitely the treatment event is a very powerful and dramatic event, but I don't know if equally as important, more important, less important. I don't want to say what's more important, but also very important is before and after. And yes, Tracy, for sure, be your own advocate.
So Crystal, did you have one more question?
No, I just wanted to touch on what you were saying about being your own advocate and getting these, I didn't know about the bone scan, so that was good to know. Thank you. But I wanted to say about cardiology, because I didn't know that was a thing, and then that was heart health was that important, even though my mom went through all of this 10 years ago. But I had gone and got a cardiology clearance before my prophylactic mastectomy these few months ago, and although my heart is healthy, he did say that I do have a very small leak. So I feel like that's not talked about enough to really make sure that, you get these things checked out. not even like when that time comes, but ahead of time, just so you're aware if there is anything there, if there is any issues, that you're aware about it, because that is something to put into consideration, you know, of when to do these surgeries to you know, lower your risk.
Yeah.
If you do maybe have a serious problem going on that you don't even know about.
So, you know, Crystal, it's just to be very, you're absolutely right. Everyone should be their own advocate. And I just want to make sure that, just so I'm very clear, the heart risks that happen after removing the tubes and ovaries, those happen over a long period of time. And it's not like structural issues like leaks and that sort of thing. It's essentially
Right.
disease, like things like, you know, atherosclerosis of the heart. And so you got to make sure the cholesterol levels stay low and that kind of stuff. So it's not something like, I'm not saying every time you get your tubes and ovaries out, you should make an appointment with a cardiologist. But what I'm saying is you need to maintain a healthy lifestyle, and then the estrogen is important as a preventative for heart attacks in the future. But just to make sure that I don't want to, if I misspoke, and I just want to make sure that everyone's clear that I'm not advocating that you have to go see a cardiologist after you get your tubes and ovaries removed. But yeah, you're right. You should absolutely be your own advocate and pay attention to these things.
Perfect. So I want to thank you again, Dr. Sinno, for coming on.
Of course.
So much education tonight. And, you know, I'd love to be able to